Hello and welcome to the RADx Data Hub tour. My name is Leah Mason and I am a project coordinator for RENCI, the Renaissance Computing Institute. RENCI is one of the RADx Data Hub partners presenting today, and we are so excited to share information with you. And I will be moderating today. A couple things for housekeeping. There we are. We'll be focusing on the RADx Data Hub, what it offers, and the studies that have provided information on social determinants of health, and an unprecedented opportunity to explore how COVID-19 disproportionately impacted certain populations. Again, we are recording today, and we will be able to share that recording within about 2 days after today's webinar. We have a really exciting agenda for you all. We'll be hearing first from Dr. Robert Hubble with RENCI, sharing a bit about the RADx Data Hub, and then we'll be handing it off to our other presenters. We will wrap up with a question and answer session, so please feel free to use that question and answer at the bottom of your screen. You'll see it in the bottom Zoom bar for you. And we'll look forward to getting those questions and answering them as best as we are able to. We are going to jump right in and get going. So I will be passing this over to Dr. Robert Hubble, and we will begin.
Thanks so much, Leah. So I'll take just a couple minutes to talk about the RADx Data Hub, what the initiative is, and highlight some interesting data, and we're just going to go right into the interesting speakers that we have. So next slide. All right, so the take-home point here is that the RADx Data Hub, the RADx initiative, which I think a lot of people know about, is this multi-part program that was created in response to the need for COVID-19 testing. Brief history, so it was launched in April of 2020, so very soon after the pandemic hit. And there are 4 main research programs that were funded, emphasizing different, unique aspects for the different programs. There was the underserved populations, RADx Up, which we're going to hear from 2 of the research projects today. They were involved with COVID-19 testing patterns in communities across the US, as well as tribal nations. There are 3 other programs that we support as well. There's RADx Rad, radical innovative diagnostic approaches, and then there's RADx Tech and digital health technologies, both focused on development and commercialization of technologies in digital health. The RADx Data Hub, so if you go to the next slide, Leah, the RADx Data Hub is a place that was, with all these studies going on, there needs to be a place for all these data to be placed, and that was what the RADx Data Hub was set up. So the Data Hub partners, of which RENCI, my group, is one. We also work with Stanford University and Booz Allen Hamilton. We've set up a place for these data to reside and for others to access those data. So there is a version up at the moment, and there'll be a major release coming in the spring. It's a secure environment, and yet anybody with the credentials can go in and access some of these data, such as you'll be hearing about today, and conduct some secondary analyses. Next slide. I just wanted to highlight that these data are, it's more than just technology. There's data that can actually influence public health beyond COVID-19. So our presentations today are going to focus on social determinants of health and the kinds of data that are available for those kinds of studies, but there's a wide range of other materials that others might be interested in. So we encourage people to explore and better understand what are out there. And if you jump one more slide, there's a secondary analysis NOSI, a notice of special interest, that is out there that the government, NIH, is encouraging people to apply to, with some innovative and interesting analyses of the data that are in RADx Data Hub. Okay, and with that, I'm going to go to the next slide. I'm going to introduce Dr. Andrea Wirtz. I'm going to say hello, and I'll let you take it away, Andrea, and I look forward to hearing what you have to say.
Great, thank you. And thanks for inviting me to be here today. I'm very happy to present some of the results from our study that really focused on transgender and gender diverse people in the United States. Next slide, please. So my name is Andrea Wirtz. I'm based in Johns Hopkins School of Public Health, and this is a large collaborative study, and it's really a community engaged study as well. Many of our co-investigators, academic co-investigators, are trans identified, and we worked with community partners as well who served as co-investigators throughout the study. So they were deeply involved in the design, implementation, analysis, and interpretation. Dr. Sari Reisner was the co-principal investigator of the study with me, and I'm showing here several of our co-investigators, Mr. Carter Brown, Ms. Marissa Miller, Dr. Tonya Poteet, Dr. Will Beckham, and Ms. Dee Adams. Next slide. So as Robert mentioned earlier, our study was one of several that were funded under the RADx Up initiative that was focused on vulnerable populations. And this came at a time we had we're leading a regional cohort that was specifically focused on transgender women in Eastern and Southern US. And the pandemic began in, I think, about year 3 or year 4 of our cohort. And we were increasingly worried about the potential social vulnerabilities and impact of the COVID-19 pandemic on transgender women. They experience significant situational vulnerabilities and are often at greater risk of adverse health outcomes. And what we noticed at the time of the pandemic was that there was a really rapid response. There was rapid collection and reporting of SARS-CoV-2 infections, mortality and death, but actually only 2 states at the time committed to collecting gender identity data in their surveillance. But actually none of them really reported gender identity at the time. And so we thought that was a really important opportunity to make sure that someone somewhere was collecting this data and reporting on the health outcomes for transgender and gender diverse people. And so we applied and received that support from the NIH to do so. And we're really interested in understanding where there disproportionate impacts on transgender and gender diverse people. What were the issues in terms of access to testing, recognizing that there are many structural and social barriers to testing and healthcare in general for trans and gender diverse people. Next slide, please. So you can go back one, sorry. Thank you. I want go back the other direction, please. So the objective. There's slide 16. Thank you. So overall, our goal initially with the study was to quantify SARS-CoV-2 seroprevalence, COVID-19 testing experiences and strategies to overcome testing barriers for transgender and gender diverse people in the US. Next slide. So as I mentioned, this was an emergency sub-study. We created a nationwide cross-sectional study that focused broadly on transgender and gender diverse adults in the US and Puerto Rico. It was implemented between June 2021 and December of 2021, the same year. We had an online cross-sectional survey that all participants completed, and then we allowed for optional COVID-19 antibody testing. We specifically didn't require that for participation in the study because this was the first time that we were doing offering dried blood spots for COVID-19 testing, and we didn't want people to feel like they had to do that and risk turning people away because they weren't comfortable with the testing. So that was an optional test for people. And we also implemented qualitative research as well to understand some of the contextual pieces around the quantitative methods or the quantitative measures that we collected in the survey. And we used our existing infrastructure from the cohort then to make this survey available nationwide. Next slide, please. So as I mentioned, we did implement the study in partnership with the Black Transgender Advocacy Coalition, Trans Solution Resource Center, and Ariana Center, and they really helped us to reach and engage with the community and to get the word out about the study as well. We focus our eligibility on people who are aged 18 years of age and older, who identified as transmasculine, transfeminine, or non-binary, resided in any US state or territory, and spoke English or Spanish language. And as I mentioned, they could complete this survey online. We also had interviewers available to complete the survey, to conduct the survey remotely for anyone who had technology or literacy challenges, and that was available in both English and Spanish languages. Next slide, please. So our main goal was under the RADx Up was really to understand the prevalence of SARS-CoV-2 infection, but we really wanted to use the opportunity to measure another number of other social determinants of health and issues that may arise for people during the pandemic. So broadly, our survey questionnaire included the common data elements that were provided by the RADx Up program, and we also supplemented with them with our own measures or other validated measures. So broadly, we covered domains of demographics, history of COVID-19 testing and barriers to testing. We asked about diagnosis, symptoms, duration, symptoms of long COVID, and vaccination. Given the time period when we conducted this study from July to December of 2021, if you recall, there were variations in access to testing and availability of the home rapid tests as well. So we asked separately whether participants suspected but had been untested for SARS-CoV-2 infection based on symptoms and exposure. And that was really important because that allowed us to catch people who may have simply thought they had COVID-19, but weren't able to access testing as many people in the US at that time were. We measured economic and social impacts of the pandemic, situated vulnerabilities, including food insecurity, a number of health history measures, including access to gender-affirming care, insurance, et cetera, disability, anticipated discrimination, and also peer support. Next slide. So as I mentioned, we did offer testing for SARS-CoV-2 antibodies, and this was an optional test. The figure that you see here shows the kit that we sent to participants' houses. So this was implemented through molecular testing labs. They sent a kit to the participant house that included a dried blood spot card. Participants could do a finger prick, leave some blood spots on that card, and then ship it back in the enclosed mailer that we had to the lab. This was important because it allowed us to detect any history of SARS-CoV-2 infection. So we detect immune response to that infection, and it allows us to differentiate from vaccine-induced immune response. Next slide, please. So overall, we enrolled over 2,000 participants in the study. The map on the left shows the counts by state. So obviously more in the more populated states like California, Texas, Florida, but we sampled participants from all of the US states as well as Puerto Rico and all the way up to Alaska and Hawaii as well. So we have a very diverse sample. You can see from the table on the right, we have diversity across geographic regions, gender identity as well. We enrolled about 30% of our sample identified as transmasculine, 27% identified as transfeminine, and 42% identified as non-binary. There's diversity across race and ethnicity. And you can see from the, from the education and income that despite that, many people completed college or bachelor's degree, some college or completed bachelor's degree or other advanced degree, so more than half of the sample, we still see some who experienced lower levels of income prior to the COVID-19 pandemic. So we're already sort of in a more vulnerable situation before social distancing and some of the impacts of the pandemic. Next slide, please. I won't go through this table in detail, but just to show some of these vulnerabilities as well. What I think is important to highlight is that at the start of the pandemic, already 13% did not have health insurance. And on top of that, another 9% reported that they lost health insurance coverage during the pandemic. 22% reported that they were also unemployed or temporarily laid off during the pandemic. And I think this is really important given all of that, we see that over 60% reported losing income in some capacity in their household during the pandemic, whether it was their own income or someone else within the household who had lost income. We see high levels of food insecurity exceeding 40%, and about 13% also reported experiencing homelessness during the pandemic. So a lot of challenges for people at that time. Next slide, please. So to our first aim, we were interested in looking at the COVID-19 infection testing and vaccination. In terms of the antibody testing that we performed, we had 23% of the sample who consented to and completed antibody testing. And overall 79% reported that they had completed their complete vaccine course by the time of the study. When we look specifically at SARS-CoV-2 seroprevalence, we divided this into actually 3 categories. So the first category was participants who had a suspected infection. These were individuals who self-reported a case they'd suspected based on symptoms and exposure, but they had no tests at the time. Confirmed, so these were individuals who had self-reported a reactive COVID-19 test, or they had a reactive antibody test through our study. And then those with a no known history, so they reported not ever experiencing symptoms or diagnosis of COVID-19 as well. Collectively, of those, we saw that about 30% reported a suspected SARS-CoV-2 infection, 10% had a confirmed infection, and 60% had no known history. Within that, within the sample overall, we saw about 34% reported that they were unable to complete COVID-19 testing when it was needed at the time. Next slide, please. So when we look specifically at correlates of suspected and confirmed infection, we ran a multinomial multivariable model. And specifically for those who had a suspected infection, individuals who lived in the South as opposed to the Northeast, who had a chronic physical health condition, a mental health condition, who were experiencing food insecurity, or who had higher levels of anticipated discrimination, were more likely to have a suspected COVID-19 infection. And this likely also reflects really the inability to test if they had a suspected infection. Similarly, we also found that people who lived in the South, who identified as non-binary or transmasculine, who were homeless during the pandemic, who experienced food insecurity, and who participated in the later phase, so September to December of 2021, were more likely to have a confirmed COVID-19 infection. And so that also not only highlights infection, but also access to testing. Next slide, please. So we tried to explore more about inability to test for COVID-19. And if you think back to this period, which feels very long ago at this point, many people experienced challenges to getting COVID-19 testing for COVID-19 when they needed it. And that was often related to scheduling or not knowing where to go, et cetera. So what we did was we looked at barriers to testing and stratified. This figure on the right is stratified by those who reported being able to access testing and those who reported being unable to access testing. So that able to access testing is the lightest gray line, and unable to access testing is that darker gray line on the top of those. And so you can see here that across all of these barriers, so while everyone reports some barrier or another, that those who were unable to access testing really consistently had the most barriers to COVID-19 testing. When we looked at these in our regression models, we found that those in the Midwest relative to the Northeast actually had lower inability, so actually had a better access to testing. But people who had Latina ethnicity, who reported inconsistent mobile phone access, who were homeless during the pandemic, who had some self-reported disability, or who relied on public transportation, were all independently more likely to be unable to access COVID-19 testing. So really a reminder of how to, the importance of low barrier access to testing, whether it's for COVID-19 or for other health conditions. Next slide, please. Finally, we've looked at long COVID as well, and this is really a growing area of research given the long-term health impacts and impacts on individual productivity as well. So among the 817 participants who had a history of SARS-CoV-2, excluding people who were asymptomatic, because this question was based on symptoms that lasted a duration of 3 or more months. 32% of those 817 reported having symptoms that lasted 1 or more months, and that's actually the current definition of long COVID. And 10% reported symptoms that lasted 3 or more months. That was the definition of long COVID at the time of the study. The figure on the right is an upset plot, and this really shows the patterns of and the distribution of symptoms that people had that were associated with long COVID. And I won't go through all of these, but just to say this x-axis reflects all of the different symptoms, so fatigue, shortness of breath, body aches, etc. And the y-axis reflects the count. So you can see here that the symptom pattern, the most frequent symptom pattern, were those of fatigue, shortness of breath, body aches, difficulty sleeping, brain fog, headaches, and joint pain. And then it decreases from there. Next slide, please. In terms of long COVID, this was what we found in our multivariable regression models, was that long COVID was more commonly reported by participants who had transmasculine identity or who were non-binary assigned female sex at birth. The numbers in these groups get a little bit smaller now that we're restricting to people with some kind of confirmed COVID-19 infection, but you can see an increased magnitude and direction of effect for long COVID for those two groups. We also found that people who reported a chronic condition with known risk for COVID-19 were more likely to experience long COVID. And we found the opposite, that people who had received at least one COVID-19 vaccine were about 50% less likely to experience long COVID. Next slide, please. So in summary, overall, we saw that about 40% collectively or cumulatively had some history of infection at the time of the study. That was in 2021, and this was slightly higher than what was reported for the national estimates. There is certainly concern for the disproportionate burden among people, transgender and gender diverse people, but those who have more common vulnerabilities like inconsistent technology access, housing instability, disability, transportation limitations. Importantly, I think to highlight is that vaccination was high. It was at 79% at the time of the study and higher than the national estimates. So really highlights that people do try to get the vaccines and try to prevent when they can. But there are significant barriers to COVID-19 testing and prevention. Long COVID was also common. And I think collectively, these data highlight that data can be collected and reported, gender identity data can be collected and reported in national surveillance, whether it's COVID-19 or other health outcomes. It's really important matter of equity to make sure that we are understanding how these national pandemics, other health emergencies are affecting all people, and ensure that research and surveillance is inclusive of these groups. Next slide, please. So because this is the RADx Data Sharing Hub, I do want to highlight some other work that's published or forthcoming. The first is a manuscript that was published by Dr. Tonya Poteet, focused on interruptions to HIV prevention and treatment during the COVID-19 pandemic. We have several publications that are forthcoming, focused on trans-specific forms of violence victimization during the pandemic, safety during the pandemic, interruptions to gender-affirming care and insurance denials, and mental health during the pandemic. The data have also been used or are being used currently for other analyses through the Data Sharing Hub. The first one is a paper by Dr. Michelle Johns that's focused on social vulnerability, prevention behaviors, and infection during the COVID-19 pandemic among sexual and gender minority people of color. And the second one is led by Dr. Gregory Phillips, focused on measuring and use of sex, sexual orientation, and gender identity data. Next slide, please. And with that, I'll close with an acknowledgement to many of the people who made this study possible, the participants, our research assistants, and to our funder, the NIH, who supported this work. And thank you to all of you for inviting me to be here today to present.
Thank you so much. We'll now pass the mic over to Russell McCullough and his team.
Great. Well, thank you for an outstanding presentation, Dr. Wirtz. And it is my pleasure to introduce our team from the University of Nebraska Medical Center in Children's, Nebraska, that will present on our work towards improving and empowering migrant families in reporting social determinants of health challenges across pretty broad geography and longitudinally. Our presenters today will include Dr. Chad Abresh, and followed by Dr. Ellen Kearns, and then our rural Nebraska-based team, which includes our research coordinators, Fernando Sanchez, Gisela Marfaleño, and our nurse case manager and community navigator, Jira Hinkle. And with that, we'll go to the next slide. Our program was funded through the Back to School Strategies portfolio and is entitled Mobile Health Targeted Community Interventions to Maximize Migrant Children's School Attendance During the COVID-19 Pandemic, and is based out of a collaboration with University of Nebraska Medical Center, Children's Hospital and Medical Center, now Children's Nebraska, and community partners based in rural Nebraska, including the Title I-C Nebraska Migrant Education Program and several community organizations across the state, as well as local health departments. Next slide. Our agenda, I'm wrapping up with introductions. Dr. Abresh will outline how we incorporated social determinants of health screening into the mobile platform that we used in partnership with families and the migrant education program throughout the pandemic. Dr. Kearns will describe our data workflows and management, and then our Central Nebraska-based team will outline our results, utilization, and impact to families. And with that, I'll turn things over to Dr. Abresh.
Great, thanks so much. So I'm going to be talking just a little bit to get us started about our social determinants of health screener in terms of its development. Next slide, please. When we started this work, obviously it was clear that there was a good deal of work that needed to be done. I've got up here a screen grab from the Nebraska legislature. LB 241 was introduced, did not pass in the Nebraska unicameral that would have adopted some employee protections for meatpacking workers in Nebraska. Nebraska has a large migrant population, migrant worker population that is vital to our culture as well as to our economy. Those workers, it was quickly realized, were vulnerable during the COVID-19 pandemic, both in terms of the lack of protections against the virus itself, but also in terms of their lack of vocational protections that were desperately needed. Senator Vargas introduced this bill, and as you could see here, it did not move forward or do well in the unicameral. Hence the need for this project. Our social determinants of health, kind of in terms of our theoretical understanding and model, is underpinned a lot by life course theory, particularly out of the field of maternal and child health. If you're familiar with the work of Neil Halfon and Michael Liu, it was largely informed by that and published in the Maternal and Child Health Journal. We're thinking specifically about this fourth component of the life course principles around timing and the understanding that there are, in fact, sensitive social structures and exposures that come into play. And understanding those and mitigating their ill effects can have long-term, even intergenerational impacts upon health. Next slide, please. In terms of our overall project, we look to enroll 400 participants. 200 of those would be students from the migrant educational program, and then an additional 200 of their caregivers. The intervention focused daily symptom screening through the mHealth tool, and then also other household risks in addition to SARS-CoV-2. So we would look at these weekly social determinants of health screenings, look for vulnerabilities that the families may be facing, either due directly to the SARS-CoV-2 due to the pandemic or other things that might be coming up in their life. And we would do interviews with participants regarding the use of those programs, reasons for testing, etc. Next slide, please. Our social determinants of health questions sought to look at things like these. What's the feasibility of mHealth screening and response for socioeconomic challenges among migrant households? Screening is relatively straightforward, but the response to challenges, that social determinants of health challenges that families might be facing, we presumed would be a more difficult challenge. Number two, what's the impact of mHealth targeted public aid and community assistance among migrant families reporting need? So we really wanted to understand, of those things that were currently in place, what is their impact? And then C here, what's the socioeconomic challenges negatively impact the ability and willingness of migrant families to safeguard their health? We suspected that this would be the case, knowing that many of these families lack the vocational protections that were introduced by the bill by Vargas. So we thought it was likely that they would negatively impact their ability and willingness to respond. And then finally, what challenges do migrant families believe are necessary to enhance their ability and willingness to safeguard their own health during the COVID-19 pandemic or other similar future events? Next slide, please. We used the Phoenix X measures and we adapted those. On the right-hand side of this slide, you can see a screen grab from our mHealth tool. So you can just get an example here and have a visual in your mind about maybe what it looked like and how they could respond to each of these things that they may have experienced within the last 2 weeks, it says. Any of the following challenges in the past 2 weeks. So just looking at a couple of these: had to delay or not receive needed medical care, not feeling your neighborhood is safe for your household, could not cope with all of the things you had to do. So we really cast a pretty wide net, again, adapted from the Phoenix X measures, but casting a wide net to understand some of the social challenges that migrant families may be facing throughout the pandemic. Next slide, please. There was a quick slide there that was really more of an infographic that you could look. We could leave this up on the screen, but sadly, there's not time to do so, and we're moving right on to the next piece. So for sake of time, Dr. Kearns, I will pass it off to you.
Good. So I'm going to talk about how exactly the mHealth tool works and then what we do with the data once it comes. Next slide, please. So in terms of the mHealth tool, in terms of the challenge screening that's within the tool, the workflow for families is as follows. They screen if I say they have any challenges. We ask if they've had assistance with those challenges, and then we ask if they would like further assistance, regardless of whether they've already had assistance, whether they would like further assistance. And if yes, we report their challenges on to our family navigator. If not, we just summarize. If they say no challenges were identified, we go ahead and present them a list of genuine resources in their area and for their time spent. Next slide. So this is how that looks. The first screen is the main screen that's presented. Slides. And then here, you can see kind of what the follow-up questions look like, and then the final thank you screens with the resources of whether they did or did report challenges and whether they did or did not request further assistance. Every button you see here in any of these screenshots is tracked in our system. And they are also associated with the household ID of the families that we put in when we registered them for our program. So we know which household clicked on which thing. Next slide, please. So that all goes into an internal database that we have, and we paired that database with some additional data, including shapefile maps that are publicly available, USPS shipping APIs, so we can track test kits that we sent out and where they've been delivered, our inventory of our test kits, because this was a testing and screening program alongside these social determinants of health, as well as all of the RADx Up CDEs in the form of red cap surveys. All of that data comes in together and is integrated in dashboard format. A dashboard page, an example page from our dashboard is displayed on the left. This is the summary that our community navigator gets. That blue box is blocking identified information, like of the people who did report their challenges, what exact challenges they reported, whether that challenge is considered a red flag, or red flag challenges are in regards to things like domestic abuse and violence, because those we obviously need to react to sooner rather than later. And then we also, beyond that dashboard, put in a lot of automated programs for notifying our team and moving the data on further. So, for example, our coordinators receive weekly messages summarizing which households haven't interacted with our tool lately, so they can follow up and see if something's going on. We have an automated email when a red flag challenge is reported that goes to a few study team members to ensure that it's not missed. If maybe our navigator misses it, it's still caught by the rest of the study team. And then we also automate an export of a CSV for upload to Duke monthly, as is required of our RADx elements. Next slide, please. So in summary, those requests for assistance or those challenges are made in our app tool, and that data is pulled into a dashboard that our navigator responds to. And then for those higher risk challenges, including experiencing any domestic violence, there is not only the summary of that report in the dashboard, but an email that goes out to the study team to make sure it's handled. We contact within 1 business day. There's an attempt made by our team to confirm the safety and refer for resources. And then if we are unable to make contact within a certain amount of time, we refer to enforcement on those higher risk challenges. And with that, I'm going to turn this over to our Central Nebraska team, starting with our family navigator, to talk about what they do with those.
Hi, my name is Jara Hinkle. I work as I'm a registered nurse and work as the family nurse navigator. And I work in conjunction with Fernando and Gisela as the community coordinators that have initial contact with the families. Next slide, please. And if you're not familiar, this is the state of Nebraska. As you can see, we're pretty diverse. Let's see, I just wanted to kind of share the darker areas. Those are the ones that are actually the most populated, the ones that we had the most participation from. onto the lighter areas. And there were a total of 99 households and a total of 407 household members. Of those, 99 were considered the head of household. Within that household, there were 104 adults that were considered in that family, and 204 were enrolled in the migrant education program or eligible for that beginning at age 5. Next slide, please.
Hi, my name is Giselle Marcolino, Community Coordinator for RADx Data. So the results are household challenges tracker use. I know Dr. Kearns already covered a little bit of surveys, REDCap, and data information. So to date, we have a total of 5,065 screens completed to date. 298 requests for assistance from 38 families out of the 99 that we have. And as you can see on the graph, the three main, and we say main, challenges that families experience where can't afford expenses, loss of income, and could not cope. On the Family Navigator piece, which Jara, Family Navigator, is the one that takes care of that. I think some of the calls that she received were regarding somebody lost electricity. There was bills that were sent to collection and stuff like that. So that counts for the can't afford expenses of loss of income. Here in a little bit, we'll touch on the Family Navigator piece, but we can go to the next slide, please. And I believe Fernando will be opening that one, and then Jara and I would add some items to it.
Yeah, thank you so much, Isela. Hi, everybody. Fernando Sanchez. So over the slide, we just wanted to give Jara more of an opportunity to kind of elaborate and just kind of talk about her experience with some of those requests for assistance that she's received. I know she has received quite a few and has helped significant amount of families with them.
Yes, I just wanted to share that of the family of, first of all, I guess I wanted to share that the ways that I was able to contact families, I am not bilingual, so that was probably too somewhat of a disadvantage, but I always did have an interpreter available. And I also had community coordinators, the assistance of Fernando and Gisela if needed. I did start out with phone calls. I even did mailings, emails with interpretation. Sometimes I did have success with that, but I was persistent. I did find that when making phone calls that it was much better to mention Gisela or Fernando's name, just because of that trust that they had already established. I do believe that part of the success of contacting and supporting families did help, that I was familiar with the communities, Nebraska in particular, had a pretty extensive history of helping with making home visits within the state and working with the school. I also just wanted to share that some of the connections that were made, I think I'm hoping that it made a difference for families. One of the first concerns that came up that I feel like there was actually action within the community was a story of a mother talking about how they were new to the community, new to Nebraska, new to the weather. And I happened to ask how their child was gonna get to school. And she said, well, if it gets cold, we're just keeping them home. So that's when we found out that the local school district didn't even have transportation in that particular area of town. And since then, that has been changed. So I'm hoping that there are more children attending school at this point in time. We were also able to work with establish a lot more trust within the community and education.
Unfortunately, we have a lot to share, but we don't have enough time. So if we're ready to move into questions, that's perfectly fine.
All right, thank you so much to our presenters. And Rob, I'll hand it to you for our Q&A session.
Sure. So I'll ask the first question. I think this is to both our panelists. When studying health equity issues, any suggestions or thoughts of including the use of geographic area-based measures to describe the socioeconomic disadvantages, and any thoughts of using Z codes to collect social determinants of health information to address health equity related issues? I'll leave it to anybody who might have answers to that.
And I'm happy to jump in on this piece. Geography ruled a lot of our project. If you could see from the map, those were school districts that the breadth of the state is linear, 500 miles as the crow flies, and the resources available in one community certainly were not going to be available in another. Scottsbluff on the far western end of the state versus Kearney or Buffalo County in the middle of the state versus Nebraska City on the eastern side. The resources have to be local, and so we do incorporate geography into how we connected resources. We were not a service provider. We also partnered with another program called MyLink that actually worked with local public libraries to establish lists of resources that could be accessed either via mobile device or internet, and had link out from our application for that, because it was that local connection that was key, and provided and made it useful.
Yeah, and I'll just add, I think that's a very important topic in terms of geographic access to resources, what are the state health policies, et cetera. And it's interesting because you can, I think for the other study, it's important to look at it at the state level, within the state, and then we're looking at it nationwide and in territories as well. And we haven't yet done that for the RADx Up data. That's actually an area that we're now moving into. We've done it for other related studies in our cohorts, drawing on state policies to look at the impact on access to care. But it certainly is an important area. I think it's challenging, I would say, in terms of timing, because our goal with this particular study was to collect the data and get the results back out quickly. When we're using publicly available data sets, there is still an additional element of accessing the data and cleaning the data to be able to merge them for these complex analyses. So that's sort of the next step in our research as well. Thank you.
This next question is going to be to you, Dr. Wirtz. So what are the best practices for asking gender and sex assigned at birth questions on a survey?
So I think to start, I'll just say it's okay to ask that. I think there's sometimes resistance to asking about sex and gender and sexual orientation. The National Academies of Medicine and Science have come out with a statement and guidelines on asking about sex and gender and sexual orientation. In terms of sex and gender, the current recommendations are a two-step approach. So to first ask about gender identity and then to ask about sex at birth. And there are other questions that can be asked about sexual orientation. So I encourage anyone who's interested in this and want to add these measures to their surveys to go to those guidelines. It is a little bit different, I would say, in the US versus other countries. And so, of course, making sure if you're using these in international settings or with migrant populations, making sure that they're adapted to local terms as well. But I think to start off by saying that it can be asked. It's been asked in the RADx Up, many of the RADx Up, if not all of the RADx Up surveys. And so I think this is really an important area. And at this point, really, health surveys should include these measures standardly.
Great. This next question is from our program officer, Dr. Shu. So compared to the general health, I'll address this to Dr. McCullough, and then maybe this will also be relevant to Dr. Wirtz. So compared to the general health access barriers, what are the unique characteristics of social determinants of health to COVID-19 testing, especially since the tests were free?
Happy to address that from at least our perspective. I think it's important for us to first highlight that more than 9 out of 10 households enrolled in our program preferred to speak Spanish and read Spanish. And so although we were presenting things in English today, everything was both translated and then user acceptance tested, meaning people went through the application to determine that they actually could get where the app intended with folks who spoke Spanish as their primary or at the very least co-equal language with English. And what we found with testing was that even using the FDA insert for interpretation, for at-home testing, for antigen testing, people were very uncertain on the interpretation of that result from home. And that the changing in recommendations, where it was first, well, do a second confirmatory test for those where you're suspected infection, but the first was negative, and then adding a third test. That was guidance that even when it was provided in more languages than English, it wasn't always language that was clear or communicated in accessible formats. And it was that timing component when we've interviewed families that was key. We actually created supplemental educational videos in multiple languages to help with interpretation and provided the opportunities for them to request for assistance, because it's not as clear as we would like it to believe, even when there's FDA approved packaging in that language.
Maybe to add on another one here, we might also think about, again, some vocational, some job barriers that relate to the social determinants of health that might make testing more or less challenging. I'm here in Omaha, Nebraska at the University of Nebraska Medical Center. If I wanted testing, there was free testing available on campus. I could walk over and get it. Even after that free testing was no longer available, I'm fully supported by my employer to leave at any time. In fact, I would be encouraged to leave at any time and test at home and take that time away. Other employers that are based here in Omaha, Nebraska, in our historically African-American neighborhood, North Omaha, have a common 12 strike practice. Where even when you take time off and it's approved time off, they'll record that as one of your 12. It's kind of like points on a license. So you move ever closer, even with a legitimate excuse, not excuse, but with a legitimate reason, you move ever closer to termination. Or the population that we were working with in meat packing plants, they have a large workforce available to them. It might just be easier to move on from an employee rather than to wait that employee's testing out and see how things go. So there's a variety of things that just from an economic and employment position make testing much more challenging.
One last question, I think, since it's 6 minutes to the hour. This is terrific. Thank you all for the answers. This is to both teams. How did you build a robust partnership with your respective underserved communities?
I would say actually for our study, it began before this study. So this is, as I mentioned, we had a cohort that had been running for several years before the COVID-19 pandemic. And we've spent a significant amount of time really trying to work very closely with community-based organizations to really address research mistrust, to really try to make sure that we're collecting and measuring issues that are important and relevant to the community and ensuring that we're getting data back into the community. And so when the pandemic hit, we brought in more formal partnerships and actually created a new model where community-based organizations, those directors served as co-investigators, and it wasn't a cab, they were involved in everything with us. They were side by side with academic partners, which also included trans-identified people. And I think that really helped to strengthen, because their expertise was fully acknowledged as co-investigators on the study, and they worked very closely to share information with the community as well. We also, throughout our study, really tried to make sure that we could provide as much benefit to people as we could. So we provided with information about affirming locations where they could access testing and other resources. We tried to provide results of the study back to them and to share results with community-based organizations when they were having seminars and other events related to COVID-19. So really thinking about it as a bi-directional relationship rather than we're collecting data and want people to participate.
So from my perspective as a community coordinator, Fernando, myself, and Jera, we work mainly and really closely with our community. I have to say that at the beginning, it was extremely difficult. Understandable so. Our migrant community, they have a lot of trust issues, and that was a difficult piece. We went step by step. The main or the key to that relationship was our community partners or community members. And then from there, it went to the MEP, which is the Migrant Education Program. And then from there, they would invite us to all their meetings with the parents. And then it was a domino effect. It started really slow. And then once we got to meet the first few families, obviously, if they hear our names, they're like, I don't know who she is, I don't know who he is. But then once the parents, additional, even their kids, the high school kids, they related a face to the name, and then the name to RADx Hub, Dr. Alcala, et cetera, it went on. And it made a really big difference once we gained their trust. And then something else that's really important has been the communication. That has been a really successful part of it, not just with the testing issues, reporting, the survey completion, the family navigator piece, red flags. We even developed a newsletter not too long ago to kind of have that information go back and forth with the families. And it's gotten to the point where if they see us on the street, they're like, oh, I know who you are, so on and so forth. When we do home visits, I know Fernando was lucky enough, a household offered him a free warm homemade meal. So it's gotten to the point where we're so close to our community. Again, it took a long time, not a long time. It was difficult at the beginning because of the trust issues. But once, they see who you are, they see what you're doing, they get updates from you, numbers, and they see what you're doing and the work that you do and the impact, for the sake of time, we weren't able to share as much as we wanted to. I know Jera shared, the school transportation. I know there were some families that we had to show them or teach them how to call 911. It's incredible to think that some families don't know who to call if they feel like they're in danger. I know Fernando and myself help some families with technical issues. Some families didn't even have an email. They didn't know how to create an email. They didn't even know where to go with the email. And those are just a few. Like I said, we had a long list of all the cool things that we've been doing and that we're really proud of in the community. And that trust came with hard work, but also them knowing the difference that we're making. And also our community partners, they know how hard we're working. Fernando, I don't know if you want to add something else. I know we're running out of time.
No, I think we're out of time.
Thank you so much.
Thank you.
Thank you all. Before we close out, I want to direct you to a link in the chat that will take you to a webinar survey to provide us with feedback. Also, I want to encourage you to register for our February webinar, where we will get a preview of the new and improved RADx Data Hub. There is a link in the chat that you can register for that February webinar. And a few closing reminders of the many resources within the RADx Data Hub. So we will drop, again, the link in the comments for survey feedback, and then just want to highlight some resources for you. When you visit the RADx Data Hub website, you can learn more about funding for secondary analysis. If you need a hand, we provide support through the Data Hub and the help desk and our contact form. We do have a user guide that provides step-by-step instructions for you using the RADx Data Hub. And also we have a new YouTube channel that shows previous webinars as well as how-to videos and many more opportunities to come. Thank you all again for joining us today on behalf of the RADx Data Hub Partners team. We are so grateful to have you here. And thank you to our presenters. Wonderful to hear from you and the work you're doing. Please continue to do that work. It is necessary. Thank you all again. Again, this will be recorded and we will send out in the next couple days. Have a great day, everyone.